Hello all, this is Dr. Aishwarya Kanave. So we are here with another new topic which is ectopic pregnancy. So in this topic, what is first ectopic pregnancy? When the fertilized ovum is implanted and develops outside normal endometrial cavity. Okay. So here the fertilized ovum is implanted and it develops outside the normal endometrial cavity. Now what does it mean by outside the normal endometrial cavity? So here we give the sites of implantation. There is extrauterine site which is tubal, ovarian, abdominal. In the tubal, the ampullary site is the most common site here, isthmus, then the infundibulum and the interstitium. So there is extrauterine and uterine, so tubal, ovarian, abdominal, ampulla, which is the common site, then the isthmus, infundibulum, and interstitial. Then there is uterine, which has cervical, angular, cornual, C-section scar. In the abdominal, there is primary, which is very rare, and secondary, which is intraperitoneal, which is common, and extraperitoneal, which is broad ligament. So these are the sites of implantation. And one key factor you have to remember, which is also an MCQ, the most common site of extrauterine implantation of the ectopic pregnancy is the ampulla. Okay, and most common tubal is done is does happen at this site only. Then the isthmus. This is another MCQ. Here, the most common site to rupture is the isthmus at 6 weeks, which is the most common site to rupture. Okay, then the last to rupture is the interstitial site. Why? Because in the interstitium, it can go up to 12 weeks. Last to rupture. It can go here up to 12 weeks. Okay, so these are some of the major MCQs that are asked. These are the one liner MCQs that you can answer directly. Okay, so we did the site. Now we will move on to the causes. So the causes are, most common cause is the pelvic inflammatory disease, then prior tubal surgery which damages the cilia. Okay, prior tubal surgery. Pelvic inflammatory disease is the most common cause, which has to be chronic. Tubal operations like ovulation induction or intrauterine device or tubal tuboplasty or tubal any kind of fallopian tube surgeries, it poses the highest risk. So tubal surgeries, okay, it has 50% risk, which is the highest. Then we have the prior ectopic, which is the second most common. Then salpingitis, it is 6 to 10 fold risk. Okay, there, in that there is loss of the cilia. Suppose this is the fallopian tube, there are cilia, there is loss of these cilia, the lumen becomes narrow, the lumen is narrow, there are pockets of mucosal folds, peristalsis is impaired, the peristalsis which is there is impaired, there is pockets of mucosal folds. See, pockets of mucosa. Then there are peritubal adhesion, kinking, and angulation. Peritubal adhesions, kinking, and angulations of the tube. Okay, and the most common causative organism is Chlamydia trachomatis. Okay, so this is salpingitis. Then contraception failure. Okay, that is tubal sterilization more than progesterone IUD, and which is more than copper T insertion, which means tubal sterilization leads to more risk than IUD, which has more risk than copper T. Okay, so then progesterone, progestat, which is also there, it has the highest risk, which is also an MCQ for y'all. Then sterilization, progesterone only pills, postcoital ectopic, that is the postcoital pill, which is also posing to a risk of ectopic pregnancy. Okay, so copper T 380A and LNG have low risk of ectopic pregnancies. So low risk is copper T 380A and LNG, which has low risk. Progestat has the highest risk. So these two are MCQs for you. So we did 4 MCQs till now. Most common cause of ectopic pregnancy. Then we have the tubal surgery as 50% risk. Then salpingitis. Why? Because there is loss of cilia, the lumen has decreased, there are mucosal folds, there is kinking of the uh, fallopian tube, and also it is because of the organism chlamydia. Highest risk is by progestat, and the lowest risk is by copper T 380A and LNG IUD. Okay, then other risk factors are infertility treatment, abdominal or any other pelvic surgery. Okay, then tubal reconstructive surgery, previous ectopic, prior induction are all uh, causes of ectopic pregnancies. Then previous ectopic, prior induced abortion, these are also factors. Then developmental defects. Okay, developmental defects like elongation, diverticulum, accessory ostia. These are important from your MBBS point of view. As such, MCQs do not occur on this. So if you have a theory paper, you can might as well write all these causes. These are all enough. Nidation in the tube, which is early resumption of pregnancy. That is the trophoblast in the tube, and degeneration of zona pellucida, increase in the decidual reaction, and then there is tubal ectopic. Then there are some changes in the tube that cause implantation. So there are these changes. We will discuss these changes one by one. Okay. So firstly, changes in the tube. Okay. So there is implantation in the intercolumnar fashion between the two mucosal folds. In the intercolumnar fashion, okay, between the two mucosal folds. So suppose there is an implantation here. Okay, there is implantation here. Decidual change at the site of implantation is minimal. Okay, decidual change is very minimal. There is hypertrophy and hyperplasia of the muscle, and the blood vessels are engorged. Okay, the blood vessels are engorged. The blastocyst, intramuscular implantation is done of the blastocyst. It is implanted intramuscularly. There is a pseudo capsule that is formed. Blood may spill from the femoral end. So suppose the implantation is tubal anywhere. Okay, and most common site, this is the interstitial, this is the isthmus, this is the ampulla, and this is the infundibulum or the fimbriae. Okay, so if it is implanted at this point, there is blood spillage from here. okay, which leads to hemoperitoneum. Then there is, if there is episodic pain, okay, it most commonly indicates that it is a tubal rupture. Okay, trophoblasts do not grow as much as in normal pregnancy, which means if the trophoblast is normally growing in in a pregnancy, the beta-hCG has to double in the next 48 hours. But if it is an ectopic pregnancy, the beta-hCG will not double in the next 48 hours. So hCG will always be inadequate. So this was about the changes in the tube. Then the changes in the uterus. Here there is estrogen and there is progesterone. Okay, so the corpus luteum, there is increased vascularity. They both act. Okay, there is increased vascularity. Decidua, no evidence of chorionic villi. This is an intrauterine pregnancy. Okay, so firstly, there is estrogen. Under the effect of estrogen and progesterone, okay, there is increased vascularity. The decidua increases. Then this indicates it is mostly an intrauterine pregnancy, but there is no evidence of chorionic villi. Okay, no chorionic villi, but now there is a decidual cast. If the progesterone falls because of the effect of beta-hCG, hCG decreases, there is decrease in the progesterone. Till the progesterone was there, there was the pregnancy was intact, but now it comes out as an decidual cast. So if it falls off, it indicates that there was a pregnancy which was intrauterine, but because the beta-hCG was inadequate, the progesterone level dropped and the decidual cast has come. Okay, then the modes of termination. Earliest interruption is at the site of where? Isthmus, which is the most common site, and it occurs at 6 weeks, is what we discussed, and this is an MCQ. Okay, then we have the tubal mole, which is complete absorption, which is very rare and which gives a small hemorrhage, which gives a very very small hemorrhage. Then there is abortion, that is pelvic hematocele is formed, that is expulsion through the abdominal ostium, that is a tubal abortion. Okay, so hematocele is formed. There is internal hemorrhage in the pouch of Douglas, which is a pelvic hematocele. So this is a tubal mole. Okay, so there is a method of termination, okay, which is a tubal mole, and it causes a hematocele in the pouch of Douglas. So first is done. This is the modes of termination. Okay, then tubal abortion. So this is the most common mode of termination, and you have to remember this. This is the most common MCQ. What is the mode of termination? Which is the most common mode of termination? Most common is the tubal abortion. For complete, it causes a pelvic hematocele either from the ampulla or from the infundibulum, and if there is incomplete, there is diffuse intraperitoneal hemorrhage. Okay, if it is diffuse intraperitoneal hemorrhage, it causes. That's it. Then we have the tubal rupture. Okay, isthmus, most common site of rupture. Yes, and interstitium, last to rupture, which is 12 weeks, as we have already discussed. Okay, so why is the isthmus most common site of rupture? So in the isthmus, the wall is narrow and less distensible, and it is eroded by chorionic villi, easily eroded by chorionic villi. Hence, isthmus is the most common site of tubal rupture. Okay, so this is the third one. So the intraperitoneum, which goes from the roof of the fallopian tube, extraperitoneum or intraligamentary floor of the peritoneum, which is from the broad ligament side. Okay, so broad ligament, and this is roof of the fallopian tube, which is intraperitoneum. Then we have the next one, which is the tubal perforation. Okay, so it causes mostly secondary abdominal pregnancy, which is rare. Again, it goes through the roof of the fallopian tube or through the broad ligament, which is secondary intraligamentary pregnancy of the broad ligament. Then continuation of the pregnancy is much, much rare. Okay, so these are all tubal abortion. See, this is the tubal mole. This is a complete abortion. This is the tubal abortion beginning. We can see the hematocele that is forming, and this is a complete abortion. Okay. Then secondary abdominal pregnancy, death of the blastocyst, complete absorption, massive intraperitoneal hemorrhage due to placental separation, infection, fistulous communication with the intestine, fetal death, mummification, suppuration, and calcification formation. Then continuation to term pregnancy, it is very rare. Risk of fetal malformation and deformation is there. So secondary abdominal pregnancy can be from the roof or the floor. Mostly it is rare, but if it is there, towards the term it is very much rare. It causes malformation, deformation, death of the blastocyst, massive intraperitoneal hemorrhage, infection, fetal death. Okay, then we have another important thing here, which is the Aristella reaction. Okay, in this Aristella reaction, it is an important MCQ as well as a theory question. Aristella reaction. So adenomatous change of the endometrial gland. Then there is intraluminal budding together, typical cell changes. Okay, typical cell changes. Now, due to progesterone, there is loss of polarity, pleomorphism, and hyperchromatism, vacuolated cytoplasm, and mitosis. Okay, so loss of polarity of the cells, pleomorphism, hyperchromic nuclei, vacuolated cytoplasm, and mitosis. And this is due to progesterone. Okay, then there is secondary abdominal pregnancy. The prerequisites for continuation of pregnancy out of the tube, that is perforation, is slow, amnion is intact, then placental chorion should escape the injury. These are very rare, but you need to know this, that is prerequisites for continuation of pregnancy outside of the tube. Okay, so if the perforation is slow, then the placental chorion should escape the injury, or it should not rupture. No rupture. Herniation of amniotic sac. Living ovum plus the placenta occur out through the vent or the wall of the tube, escape out. Then HCG, Then we move on to the clinical features of ectopic pregnancy. So first is we have the acute, then the second one is the subacute, chronic or old, then the third one is the unruptured. So we will first start with the acute. It is less common. It is 30%, and there is tubal rupture or tubal abortion, plus there is massive intraperitoneal hemorrhage, and it occurs at the age group of 20 to 30 years. There is nulliparity. There is unilateral uneasiness, and it comes with a triad, that is amenorrhea, 6 to 8 weeks of amenorrhea. Then there is abdominal pain, which is a 100% feature, and the abdominal pain is colicky. Then there is vaginal bleeding, which is 70% of the symptoms, and there is expulsion of decidual cast. We already discussed about the decidual cast. And the amenorrhea feature is almost 75%. Okay, and if there is abdominal pain, there is a shoulder tip pain also, which is a referred pain, and it is mainly because of hemoperitoneum. Okay, there is vomiting, there is fainting attack, there is a syncopal attack, there is hemoperitoneum, and there is peritoneal irritation, and there is a reflex vasomotor symptom which causes a syncopal attack. Also, on examination, there is perspiration, there is pallor which is present, heart rate is rapid, cold clammy extremities, hypotension, abdomen is tense, and there is tenderness, and the vaginal mucosa is uh, like it is pale. There is a plain or pale or blanched vaginal mucosa. And then the uterus is bulky. So this is acute clinical features. These are the clinical features of acute ectopic pregnancy. In subacute or chronic or old, the onset is insidious. Amenorrhea is present of 6 to 8 weeks, plus lower abdomen pain, plus vaginal bleeding. Scanty. The vaginal bleeding here is scanty and dark. It is continuous. Decidual cast present. Dysuria. Increased temperature. And on examination, the patient is pale, pallor present, increased temperature, per abdomen is tender, mass is present in the lower abdomen. There is a Cullen's sign, that is a bluish discoloration around the umbilicus, and boggy tender mass in the pouch of Douglas. Again, there is pale vaginal mucosa. Then we have unruptured ectopic. In unruptured ectopic, there is abnormal bleeding or spotting. There is mild pelvic pain. UPT positive, amenorrhea. Uneasiness on the side of the flank. Uneasiness. Then colicky pain on bimanual examination. Pulsatile. Small. Well circumscribed. Tender mass. Felt through fornix. Cervical motion tenderness is present. Uterus is less than the period of amenorrhea. On TVS, okay, on TVS, the uterus is empty. Okay, then gestational sac is seen in the fallopian tube. Okay, on Doppler, there is a ring of fire kind of appearance. Minimum amount of β-hCG to see the gestational sac. On TVS is 1500 and on TAS is 5000 to 6000. Okay, so this is the flow chart of acute, subacute, chronic or old or unruptured ectopic. Even if you memorize this chart, you will be able to answer in your theory exams or in your practical exams. And apart from this, the next thing we are going to see is how do we diagnose it. So we do the serial β-hCG monitoring here. Okay, first we have is the acute. In the acute, there is history of fainting or collapse. Okay, then in the differential diagnosis, there could be acute appendicitis. Okay, and corpus rupture of the corpus luteum. Okay, and UPT is negative here. Okay, then twisted ovarian tumor or a ruptured chocolate cyst. What is a chocolate cyst? We have already seen in our last endometriosis chapter. Then subacute, no amenorrhea, no vaginal bleed. To that extent, there is vaginal bleed, but to a very less extent. Okay, very scanty it is. No major vaginal bleeding is present. Therefore, there is vaginal bleed. Then there is pain. The condition is normal. The patient gives history of tubectomy or intrauterine device. Okay, then in the investigations for the tubal ectopic, we do the hemoglobin, the WBC, the basic blood counts or culdocentesis, 18 gauge needle. What is culdocentesis? 18 gauge needle is put through the pouch of Douglas. Aspiration of non-clotting blood, okay, is done, and HCV, if more than 50%, 15%, it is a ruptured ectopic. Okay. Then there is β-hCG. Hmm? UPT is done. It is sensitive to 10 to 50 international units. Beta-hCG estimation, lower concentration. Beta-hCG has low concentration as compared to normal pregnancy. Doubling time fails to occur. So as we have discussed earlier, it will not get doubled as in normal pregnancy. Okay. On USG, okay, absent intrauterine pregnancy. Hmm. Then there is fluid. And as we discussed earlier, there is a ring of fire appearance, enhancement of blood flow outside the uterine cavity, that is in the fallopian tube. Okay. Then the beta hCG values, as we discussed, TVS it is 1500, TAS it is 5000 to 6000 for detection. When beta hCG is more than 1500 with an empty uterine cavity, it is ectopic, failure to double by 48 hours, which is another sign of ectopic. Then we take the serum progesterone into consideration. It should be more than 25 ng per ml. Okay, if less than 5 ng per ml, it is a clear cut sign of ectopic or abnormal pregnancy. Okay, then there are some differential diagnosis of this subacute ectopic pregnancy. In subacute ectopic pregnancy, incomplete abortion can be there. Incomplete abortion. Then there is bleeding. Here also there is bleeding. There is pain. There is fainting. But the color is bright red of the blood. There could be salpingitis. These are all differential diagnosis. Okay. In interstitial pregnancy, of 12 to 14 weeks, thick vasculature, greater distensibility. So it is here. Okay, interstitium. It is here. It is thick. It is vascular. The termination is rupture. It can cause intraperitoneal hemorrhage. Hmm. Then diagnosis on laparotomy. Laparotomy has to be done for this. And the termination is as rupture for this pregnancy. Okay. So the next thing we move on, there is some clinical presentation of the ruptured ectopic. If there is ruptured ectopic, as we discussed, there is severe pain in the abdomen, there is amenorrhea and mild bleeding per vaginum. Okay, there is expulsion of the decidual cast, and then there is rupture, or there is a Cullen sign that we have seen, that is a boggy tender mass, cervical motion tenderness is present. And how is it treated? It is immediate laparotomy, resuscitation with self-injectomy. In unruptured, we usually do the investigations. So one basic concept, one last concept, that is, in the diagnosis, the gold standard is laparoscopy. Okay. Before we move ahead, we do the serial beta hCG monitoring. In this serial beta hCG monitoring, firstly, if there is a rise in beta hCG more than 66%, it is a live gestation. Then if the rise is less than 66%, it is ectopic. If there is fall in β-hCG, it is a failing pregnancy or abortion. So this was the last thing about diagnosis of pregnancy and what are the clinical features of a ruptured ectopic, what are the clinical features of acute, subacute, chronic and an unruptured ectopic. And the ring of fire appearance is a typical MCQ question that you have to study and go. This question. This is an important question. They will give you a case scenario and then they will mention there is a ring of fire presence in the USG. So the management of tubal ectopic, in this detailed history, evaluation of high risk factors and examination is done. Urine, β-hCG, ultrasound scan, transvaginal is preferred. Then there are some clinical features. Beta-hCG is negative here. Then the beta-hCG is repeated in 1 week. If that is also negative, pregnancy is excluded. Then there are some clinical features, but beta-hCG is positive. On TVS, there is a discriminatory zone on 1000 of 1500. If it is an intrauterine sac, beta-hCG, as we discussed, increases in 48 hours. Serum progesterone more than 25. Repeat USG, intrauterine pregnancy. Okay. Then empty uterine cavity with adnexal mass. Laparoscopy is done. Okay. Laparoscopy is done. We will discuss the rest of the part after the third point. If beta-hCG is positive, there is a strong clinical feature. Patient is in shock and unstable hemodynamically. Then resuscitation and laparotomy. Ruptured tubal ectopic pregnancy. Then we do the self-injectomy. Now, in unruptured tubal ectopic pregnancy, we have 3 lines of management. That is expectant, medical and surgical management. Okay, in the expectant management, we don't really do anything. It resolves on its own. Beta-hCG less than 1000 and falling beta-hCG titer, ectopic mass less than 4 centimeter, no evidence of bleeding or rupture on TVS. Okay, follow up and the patient is clinically stable and pain free. Then we have the medical management. In the medical management, the sac size is less than 3.5 centimeter. Okay, then the beta-hCG is less than 5000. There is no FHS, but the patient is hemodynamically stable, no significant pain, and that is managed medically by Methotrexate 50 mg per kg per meter square, sorry, or PGF2 alpha. Okay, and there is no evidence of intra-abdominal hemorrhage. Okay, actinomycin can also be given. And beta-hCG is again measured on day 4 and day 7. Okay, then we have that is so here they have already given methotrexate and potassium chloride, then systemic methotrexate, actinomycin. So surgery, laparoscopy or laparotomy, there is significant pain, sac size more than 3.5 and beta-hCG more than 5000. Okay, so if there is conservative management expressing out from the distal tube, salpingostomy or salpingectomy, then extirpative, that is salpingectomy or a segmental resection. Okay, so what is salpingectomy? Complete removal of the tube. So here we have salpingectomy, that is we remove the tube completely. Salpingostomy is incision, remove and suture the contents. So incision, remove and suture the contents, that is salpingostomy. Then we have salpingostomy, that is incise, remove and keep open. So we remove it and we keep open, that is gostomy. Injectomy is removal. So see, there is salpingotomy, it is incise, remove and it is kept open. Then medical management, mostly methotrexate is given. Beta-hCG fall more than 15%. Beta-hCG, as we discussed, is done on day 4 and day 7. If the fall is more than 15%, it is working. If the fall is less than 10%, one more dose is given of methotrexate Okay, and what else is given? uh, PGF2 alpha is given, mifepristone is given, vasopressin is given, KCl is also given. These are all NEET PG questions. If decline is less than 15%, second dose is given on day 7. So methotrexate doses are given on 1, 3, 5 and 7, that is 1 mg per kg. Single dose regimen was 50 mg per meter square, and these are multiple doses that are given 1, 3, 5 and 7, 1 mg per kg. Then leucovorin, that is 0.1 mg per kg on even days, that is 2, 4, 6 and 8, and weekly beta-hCG until 5 milli international unit per liter. Okay, then there are surgical procedures, laparoscopy. Then there are surgical procedures which is laparoscopically, okay, linear salpingostomy as we discussed. Then there is segmental resection. These are the three types of surgeries that are done. Then also persistent ectopic pregnancy due to incomplete removal of the trophoblast does exist sometimes. Then we have the different kinds of pregnancies, that is abdominal pregnancy, primary implantation of fertilized ovum. Okay, that is Studiford's criteria, bilateral ovaries and tubes are normal. Then secondary conceptus escapes out through the rent in the fallopian tube, through the rent in the uterine scar. Then there are symptoms, that is there is history of through the rent in the uterine scar. Okay, then there is history of disturbed tubal pregnancy, that is pain in the lower abdomen, nausea, vomiting and increased or abnormal fetal movements. Okay, then signs, that is the Braxton Hicks are absent, those contraction, and on PV it is only 12 to 16 weeks. Abnormally high position of the fetus, no uterus around the fetus. Then management is urgent laparotomy. Okay, if continued there is fetal death. So the only thing to remember, what are these criteria called? The abdominal pregnancy is called the Studiford's criteria. Then we also have ovarian pregnancy, which is called as the Spielberg criteria. And tube on the affected side is intact. So suppose uh, here is the ovarian pregnancy. So tube on the affected side is intact here. Okay, the gestational sac must be in position of the ovary. So the gestational sac must be here. The sac is connected to the uterus by ovarian ligament. Okay, so here is the ovarian ligament like that, and it is connected to the uterus, and the sac is here. The sac is here. Then ovarian tissue must be on its wall. So ovarian tissue, it has in its wall. Then we have the cornual, rudimental horn of the bicornuate uterus, 12 to 20 week, that is intraperitoneal hemorrhage, that is cornual. Then we also have cervical, that is the Rubin's criteria. And in this Rubin's criteria, it is present in the cervical canal, erosion of the walls by the trophoblast. Then painless and uterine body lies above the distended cervix. Then soft and enlarged cervix equal to or larger than the fundus. So the cervix is enlarged like that wherever it is implanted. Uterine for bleeding followed by amenorrhea or cramping. So then there is bleeding followed by amenorrhea or cramping. Then the products of conception are present in the cervical os. Then there is villi in the cervix. Pregnancy of uncertain viability, which is the next one. Okay, intrauterine gestation of less than 20 mm, no yolk sac, less than 6 mm CRL, and no FHS. Okay, so this was all about the ectopic pregnancy. If you like the video, please share the video so that it helps most of the MBBS students and the batches going for NEET PG examinations. And here are some images. This is a laparoscopic view of unruptured ectopic. Immediate laparotomy has to be performed in such cases. And this is the interstitial pregnancy. Then this is the ruptured interstitial pregnancy. Then this is self-injectomy. This is the cornual pregnancy. Then risk factors of ectopic pregnancy. History of PID. This we have already discussed. It's just a revision. History of PID, history of tubal ligation, contraception failure, and in the contraception we have an MCQ, that is the progestat. Progestat has the highest risk, and CUT 380A has the lowest risk, with LNG IUD, which also has the lowest risk, and then previous ectopic, then history of infertility, IUD use, previous induced abortion, and tubal endometriosis. So this was all about ectopic pregnancy. Thank you very much. See you in the next video.